Okay, welcome. Welcome to the 2014 LaTour Eichenwald Forum on HIM Leadership and Innovation. Before we get started, I just want to point out that if you have a rental car, a Hyundai Blue, where it says replacement cost approximately $225 for these keys, come see me after the event. I only charge $125, so it's a good deal. Is that you? Okay, well, I'll get them to you. Well, my name is Ryan Sandifer. I'm the chair of the Department of Health Informatics and Information Management here at the College of St. Scholastica. And on behalf of the College of St. Scholastica, the School of Health Sciences, and the HIM department, I would like to thank all of those who are in attendance here on the Duluth campus, as well as our friends who are viewing the event via online streaming. Before we get started with tonight's program, I wanted to first thank a few individuals for their support of tonight's event. First, I would like to thank all of you who have donated to the LaTour Eichenwald Forum Endowment. Your generosity has been remarkable over the past 3 years. We continue to fundraise to meet our endowment goals, so if you are interested in donating to this event that we hold annually, please let myself or Nancy Kriego know, and we'd be happy to work with you. And I'd also like to thank all of our current students who are in attendance here today. This year we have 57 master's students participating in their graduate capstone, and this is the largest graduating class in the history of the master's program. They come from near and far. Some students hail from here in the Twin Ports of Duluth and Superior, and we have students who have traveled many, many miles to arrive, including one from as far away as Ghana. Welcome to Duluth and the College of St. Scholastica, and congratulations on a very successful poster session earlier today. You all did fantastic. I'd also like to thank Lindsay Lottie and the Graduate Extended Online's department for providing support for tonight's reception. I'd also like to thank Sarah Libin and Cheryl Zupek and Bob Aschenmacher for their marketing support. And I'd like to thank Sue Mackey and the Mitchell staff for the use of the space and the technology to support tonight's event. And finally, I'd like to thank Nancy Kriego and all the other college faculty and staff who have worked hard to organize and coordinate this event. It's been a lot of work over the past year, and I think it's turned out very well. So thanks to everyone. And a little bit about the event. I'm very excited about this. I think it's my favorite event of the year. It's an opportunity for us to collectively look back at the history of the department and honor two of its finest professionals, Kathy LaTour and Shirley Eichenwald Mackey, and also look forward to the challenges and opportunities for the profession through the eyes of an individual who exemplifies Kathy and Shirley's innovative approach to leadership and commitment to the HIM profession. Tonight, we are lucky and fortunate to have Gail Graham with us to offer her thoughts, and I'm very excited to hear her presentation. Before we move on to Gail's presentations, we have one more order of business, and each year the department honors a student with the Margaret Amadiakal and Marita Johns Graduate HIM Research Award. Margaret and Marita were foundational to the development of the master's program here at St. Scholastica, and they continue to demonstrate research and scholarship in the field. The award is given to the HIM graduate student whose research poster best exemplifies research excellence and innovation, contribution to the HIM profession, demonstration of creativity, and incorporation of the Benedictine values. The winner of this year's research award is Christy Lundgren, who works at Children's Hospital and Clinics of Minnesota. Christy's project is titled Enterprise Record Management, and basically, if I can summarize this in a nutshell, Christy developed and implemented a framework, a process, and the tools to document and track all of the data within her organization, including changes made over time. With all of the focus lately on the implementation of electronic health records, Christy's project provided a great example of integration of information governance within a healthcare organization. Help me congratulate Christy Lundgren on this successful project and her award. Thank you, Christy. Good job. And I would like to now turn it over to Dr. Ron Berkland, the Dean of the School of Health Sciences, to introduce our keynote speaker tonight, Ms. Gail Graham.
Thank you, Ryan, and good evening to everyone. It's my pleasure to welcome you here tonight, too. Of course, the Department of Health Informatics and Information Management is a part of the School of Health Sciences, and this is probably the right audience to say it is undoubtedly the most advanced and best department within the School of Health Sciences. It just seemed like the right place to announce that. Well, it's my pleasure tonight to introduce Gail Graham as the keynote speaker of this year's LaTour Eichenwald Forum on HIM Leadership and Innovation. And as you know, the purpose of the forum is to honor the legacy of two pioneers in the HIM field, Kathy and Shirley, through a keynote address by an individual who exemplifies their leadership qualities. Gail most definitely meets that requirement. Gail Graham serves as Assistant Deputy Undersecretary for Health for Informatics and Analytics within the U.S. Department of Veterans Affairs, Veterans Health Administration, Office of Policy and Services, and directs the Office of Informatics and Analytics. In her role, she leads efforts to ensure VHA's clinicians, managers, leaders, and the patients they serve are provided timely, relevant informatics products and data resources that support improvements in veterans' health care, including managing data contained within the VA system's EHR and related data systems. She leads a staff of approximately 650 within VHA's Office of Informatics and Analytics. Gail constantly works to foster the technological advancement of health information systems to improve quality of care for patients. She has led VA participation in several public-private sector initiatives, such as Consolidated Health Informatics, the National eHealth Collaborative, and the American Health Informatics Community, which created the foundation for the Nationwide Health Information Network. She is a key contributor to the development and advancement of the VA Corporate Data Warehouse and the Health Informatics Major Transformational Initiative. She also is essential to the advancement of Veterans' Personal Health Record, including the VA Blue Button Initiative and My Health eBet. Gail was ranked as one of the 100 most powerful people by modern healthcare and named a top 10 IT innovator by Healthcare Informatics. She's also a recipient of the American Health Information Management Association's Achievement Award. Gail has had an accomplished career as a creative executive, and her vision has helped transform the VHA. We're extremely fortunate to have her here speaking with us this evening. Please join me in welcoming Gail Graham to the College of St. Scholastica.
Thank you. Good evening. I just want to thank the planners for this event for the invitation. It's always my pleasure to honor, in some small part, people that have really contributed and shaped my career, and for that I want to thank you. I also want to comment on how impressed I was by the poster session. I thought the topics, as you will see, were so timely considering the healthcare environment that we're in today. Before I begin my formal remarks, I just, some of you may have noticed that there was some press here during the day this afternoon, and some of that's attributed to this event, and I tried to, as best I could, to steer to this event. But it's also attributed to the recent press surrounding the Department of Veterans Affairs. I've worked for VA for 27 years. Remain proud of our mission, and I'm confident that some of the issues that were identified will be rectified, and I believe that I know that my staff, the HIM staff, the analytics staff, have done worked tirelessly over the last month as they were the first to volunteer to do site assessments, to analyze the data, to write the reports, and that really is this era of increased transparency is really important to VA really getting back the trust of the veterans that we serve. So just want to try very hard to make sure that anyone who asked knows that this is an essential part of VA or any other organization, and that's hiring and finding and recruiting and training talented individuals such as yourselves in positions of authority in our analytics area, in informatics, in traditional HIM practice. So I just want to thank you for the initial invitation and for keeping me on as a speaker today. So thank you. Just briefly to go over the agenda for my comments, and then we will have time for questions at the end, just to give you a little bit of background on the environment from which I'm speaking and how current U.S. policies impact that. VA and what we're calling connected health, or how we connect with veterans other than kind of the traditional face-to-face encounter. And one of the initiatives we have that actually one of your student site was involved in one of the 12 pilot sites. And this is really training a cadre of analytics staff throughout the country. Madison was one of the 12 initial pilots, and it was really taking a program that began at the Omaha VA and expanding it across the country so that we could be assured that every hospital had trained analytics staff, that we provided them both technical and university course curriculum. And finally, the impact on N2 health information management. I have a lot of opinions about this, and if you've ever met me or if you've ever talked to any of my staff, you know that I do not believe that there's any role in healthcare that health information management should not be involved in. I mean that sincerely from across every aspect of the organization, and I think VA is a good example of that, where you see people that are hospital directors, you see them that be program officials, you see them in various traditional roles in HIM, but then applying those HIM skills much beyond that. So now you know where I stand. So I just want to say again what a pleasure and honor it is to be here to deliver the keynote for the LaTour Eichenwald Forum on HIM Leadership and Innovation. I've long been a supporter of the College of St. Scholastica. I've had several staff that came out of Scholastica, but we've also, Scholastica has been wonderful for both undergrad and for the master's program for our current staff. And I thank the excellent leadership here and instructors for producing even greater individuals than I had going into their endeavors to further their education. And as you all know, Kathy LaTour and Shirley Eichenwald are leaders in the field of HIM education. Not only did they initiate the first electronic health record training lab, they have co-edited multiple versions of their essential textbook, Health Information Management Concept, Principles, and Practice, or to those of you that are my age, the replacement for Edna Huffman. So just a little bit about VA. So just as Shirley and Kathy led the transformation of HIM education and the HIM practice, I will plan today to share some of the transformations that are occurring within Veterans Health Administration. First, I will set the stage with a brief description of our environment, as you see on the photo here, and I will describe some of the U.S. health information technology policy priorities. I'd like to really describe the impacts of information. I'd also like you to pay special attention where we haven't figured this out, where we don't really know where patient-generated data should be stored, where it should come into the care process, or for that matter, who governs it. So there are so many questions to be answered, and it's people like you that will help us get to those answers. So as you can see, we're in Vision 23 right now, which spans Minnesota, the Dakotas, Nebraska, and Iowa, and a few sites in between. There are 21 of those networks across the country, and they have leadership within those areas. Across the U.S. and the territories, there are 151 medical centers and a number of outpatient clinics. These clinics can be a variety of things. They can be co-located in community hospitals. I was lucky enough to be one of the people that went out on the audits over the last few weeks and saw an example of a clinic in Carroll, Iowa, where the community so wanted the presence that they actually gave a wing of the hospital for the clinic. And in that case, those veterans went back and forth between the clinic for inpatient services, for laboratory, for diagnostic services. I also visited a clinic in Fort Dodge that was comprised of contract staff plus VA staff. So you will see large and small. One of the things that I was so impressed with was the ease at which they transitioned to telehealth. So, for example, if the psychiatrist wasn't in the clinic on that day, but they had a veteran that presented, they really seamlessly could transition to accessing a tertiary facility mental health provider for that veteran. And it's something that we try to promote and fund centrally, but to see it actually in action was a great thing to see. Vet centers actually emerged during the Vietnam era when there was a real mistrust of the VA and the government as a whole. And vet centers today still remain, from a privacy perspective, a separate entity. If a veteran is seen by a counselor at a vet center, we do not see that information. The VA health care providers do not see it unless the veteran releases it to them, authorizes for their access. And I think it is an example of true kind of patient autonomy over their data. We also have mobile vet centers, and if you read our Secretary's remarks on Friday, the mobile vet centers are frequently deployed in times of crisis and hurricanes and in other natural disasters, but they've also been deployed to Phoenix during this time. Residential rehab programs are those for a variety of reasons where a veteran needs readjustment back into society. They may live in these domiciliary programs. And then what used to be called nursing homes that are really transitioned to community living centers across the country. So one of the common things through all this and through the last 4 to 6 weeks is this whole increase in transparency. And that increase in transparency really requires that you know your data, that you make your data available freely. And but with that comes the responsibility to make sure your data, the accuracy of your information. There's one thing that existed before recent events and will exist into the future, and that is that the mission of VA to serve those who have borne the battle and their spouses and their children is still one of the most noble missions within the government, and we certainly will, strive to make sure that that's fulfilled. VA, like many other healthcare organizations, has been on this transition and road to patient-centered care. To that end, we hired Dr. Tracy Gaudet from Duke, who had actually began their patient-centered care practice. This really brings in holistic medicine, traditional medicine, and really focuses on what is the desire of the patient. Not that I want to reduce my blood pressure, but that I really want to improve my life so that I can walk to my grandchildren to school, or really translates it into what's meaningful in my life. And I'll talk a little bit later about the living health assessment that helps us as a tool. This whole idea of team-based care that providers, provider extenders, pharmacists, nurses, dietitians work in teams to deliver care. This whole point of data-driven, evidence-based healthcare. And like many, when we implemented electronic health records, we really got into this whole cycle of clinical reminders and alerts, and to the point where I think remains one of the biggest problems with electronic health records is this whole thing of alert and reminder overload or fatigue from all of these things. So one of the goals in our next generation electronic health record is really to customize those alerts and reminders so that they're very specific to that patient and not just a generic intervention within the care process. And this whole focus on prevention and population health. So we're working with, in a cooperative research agreement with IBM and the Watson engineers to look at, are there things we can predict? I think we've gotten pretty good at predicting what are potential readmissions, but then the secret is how do we intervene to avoid those readmissions? And I know you had a poster session on that where the example that was used there was, do people leave the hospital post-discharge really not understanding their instructions for medications or their post-op or post-discharge instructions? And I think work like that is just essential, that we understand what patients hear. There's a lot going on the days you're discharged from the hospital, with organizing with your family and organizing your house for your homecoming. So really taking a look at what are those things we could do to facilitate patients becoming and remaining in their homes. And providing value. I think for many years its value has really not been a label or a concept that we discussed in healthcare, but I think with the Affordable Care Act and with competition and with greater transparency into cost, that this whole issue of value, I know we've visited with United Healthcare several times over the last year, and they've built lots of tools so their constituents can see, that a CT scan costs this much at this facility in the area, and it costs, another amount here, and what their quality measures are. And I do think you see more and more consumers really being more informed about the choices that they make. And this whole point of continuously improving, being a continuous learning organization. So just to give you an idea of the scope, we serve almost 9 million veterans that are enrolled. Like many healthcare organizations, not all of them receive treatment from us every year. And this year, the impact to VA with the Affordable Care Act is we are considered credible coverage for those veterans who qualify for VA healthcare. So we spent a lot of time educating veterans on the tax credit and what it meant to be credible coverage, and had a slight increase in enrollment with that change in the larger national healthcare environment. So one of the posters was about big data, and my staff likes to say we were dealing with big data before it had a name, because we were dealing with data from across the country on millions of veterans, and have had electronic health record data nationally since the 90s. So it's something we're still learning and engaging with other healthcare organizations. We have active participation with Kaiser Permanente, with Johns Hopkins, and others, just so we can learn from each other how you really learn from this data. Having a lot of data sometimes can be a blessing and a curse, but really making it work for you. And you can see here the number of prescriptions, and uniquely prosthetic services. We develop prosthetics. We engage in the innovation in prosthetics for prosthetic limbs, eyes, for any number of prosthetics devices. We also are probably unique in that we will also equip vehicles, homes, and things too for veterans that have what's called a service-connected condition. So we're fortunate to work closely with Dr. Karen DeSalvo at the Office of National Coordinator, and we've actually been involved with the Office of the National Coordinator for since its inception. So one of the things that is really important to us right now, in conjunction with our work with Department of Defense, and actually in conjunction with the Health Information Exchange activities, is this whole idea of really furthering health data standards, and not just identifying the standards, but also identifying the implementation route to put those standards in place. So we're working closely there. And really to further the use of electronic health records to capture and share meaningful information. Frequently, the information in electronic health records, for example, it has not always been easy for us to do our quality measures by just pure extracts from the electronic health record. So we still do engage in what's called an external peer review program, where they actually come in and do chart reviews still, although they can do those remotely. But we're really transitioning over the last year, this year, and years to come in transitioning to population-based measures instead of those sample size measures. Interoperability, we've learned a lot. There was a poster, one of the VA employees that's part of your curriculum. Nellie had a poster on, kind of some of the things that we've learned with interoperability. Kaiser Permanente in San Diego was our first sharing partner. We try to refine every day. We're still working on things that you would think would be fundamentally easy, like, is this the same person? But it turns out it's not so easy. And in discussion with large vendors that do this too, like ShareScripts and others, that identity issue remains what I think is probably our number one challenge in interoperability. Is this the same person? And we have had talked to other countries, we've worked with the vendors, we've talked to other healthcare organizations, and figuring this out is also a challenge that I think that students in your position really could contribute to. So the whole idea of consumer engagement, and is that at all levels of social economic scale? Do you include the consumers in their decisions for healthcare? We've done some work looking at how we can use research to array options for treatment, for example, for different conditions. And with those options, array what are the outcomes that come from those options. So, the difference between invasive surgery and diagnostic treatment for different cancers, for example, to just make sure that the consumer is informed of all of their options. And this improved reporting of clinical quality measures, as I talked about right now, a lot of our measures are pulled in a sampling technique with chart reviews. That's certainly something we would like to get the electronic health record to a state to be able to do. And one of the challenges is this kind of balance between requiring discrete data entry by the clinician versus free text. And right now we're clear over here in the largely free text arena. We've had counterparts that went to this very tightly, very controlled entry, but sometimes when you read those notes or the information, it really doesn't give you a lot of meat. It's really difficult to then transition into something that's readable and understandable. So I think balancing that of being able to pull the information that you need for quality measures and with the flexibility that you allow the providers, I think is another area that really HIM could do a lot to look into that and come up with some innovative ideas. So I felt good about the fact that our office is closely named to your programs here, and uniquely we do bring together health informatics and the whole array of physicians, nurses, allied health professionals, HIM professionals. We have a traditional HIM department, but they're advising everybody. They're advising other offices, they're advising offices within our own office, and this whole growth of analytics that we've seen, that also has a broad array of different disciplines, from clinicians to HIM professionals to those with IT backgrounds and those with laboratory backgrounds. So I think that diversity in those viewpoints really makes us stronger in many of these areas. So from a business perspective, the healthcare industry performs only two kinds of actions. And considering the vast array of things we do, it's interesting that this author could boil it down to these two. This medical procedures to support diagnosis, therapy, or disease prevention, and the acquisition, use, and communication and storage of information. That information has become so important to how we deliver health care, to how we coordinate care. So for example, in our organization, we provide care, we purchase care, and we also know that our veterans are seen in Medicare providers and through DoD TRICARE providers. That being able to array that data so that you can successfully manage those conditions is of vital importance. And I think for most of us, we don't see one provider or even one healthcare organization traditionally. So the heightened importance of data, I think we have not seen the end of that yet. I think that will continue to grow in importance. So one of the topics we're going to talk about is connected health. This is the name that we landed on after much analysis of really what is this environment that we're in today. So we did an environmental scan in conjunction with a consulting company, Deloitte. And one of the things that they really focused on us was don't focus on the technology, because as several of you pointed out, the technology is changing just at such a rapid pace that I know in one of the posters it was first we introduced the computer and then the iPad and then the phone and whatever device may come along. So it's really that aligning of virtual care technologies to create a unified, seamless experience for veterans across VA-facing technologies. Where we found ourselves was we had developed a personal health record that had one look and feel. And then we had developed patient kiosks that were put in medical centers and clinics, and they had a slightly different look and feel. And then we had developed telehealth interventions over here, and at the end of the day, it was the same veteran looking at all these things, but their medications may look slightly different as they looked at them through a kiosk versus how they looked at them through our personal health record. Some of that's understandable. They were separate projects. They were developed at different stages. And our effort now really is to make that a uniform experience for the consumer so that they really have the same look and feel. And I'll talk about it in a minute. We did some of this with Blue Button, where we worked with the other parties to say, when you present lab findings, present them in this way so it's not confusing to the consumer when they receive their lab, whether they receive them from DoD or through a lab vendor or through VA. So it's the reference of this is under My Healthy Vet has been the label that we've had on our personal health record for some time, and it's become something that people hang things off of. It's referred to sometimes as a Christmas tree, and we're trying to get that under control. So I'm just going to go through a little few of the components that are there. One of these is secure messaging. It's really to provide a secure means by which an individual can talk to their care team. These come in through our personal health record portal. We had, looked at the HIPAA legislation on emailing patients, and we had spoken with several that had implemented provider-patient emailing and decided that this was probably the most secure way to go. So patients are alerted when they have a response from their provider, and the providers check these every day. That involved HIM and the providers writing guidelines that relate to these secure messaging. How frequently should they be answered? What kind of disclaimers do you give to the patient when you engage them in secure messaging? But it really sets up that way, and you'll see in a testimonial here in a few minutes that many veterans, young and old, have really embraced this. that's the other thing we frequently are asked. Well, isn't it only your young clinicians that embrace the electronic health record, and isn't it only your young veterans that are really interested? But I would say from our experience, that's not the case. I think you see a full spectrum and actually increased interest on either side, with kind of those in the middle, my age being the least in adoption in our experience. So right now, we have a cumbersome process. You have to either go into a medical center or clinic and you do a face-to-face authentication. We would really like to move to a federal proofing for participation in My Healthy Vet and secure messaging and all of these things. We do take the credentials that are offered by Department of Defense, and we're working with other organizations such as USAA, the insurance carrier, to use their authentication. But it is currently probably one of the biggest obstacles to adoption, this requirement, kind of a burdensome requirement. Some of the things we're adding is the ability to, for the patient to add attachments to their message. You know, if they have an outside consult from another provider or outside laboratory findings that they want to let their provider know about. And for many HIM professionals, and it gets around to this point of, is there workload credit, or can I code this? Is there reimbursement for this exchange? And I think that that's all over the board. We, internal to VA, we don't bill them, but we do see that activity and know that that provider is spending X amount of time. Many providers were very concerned that they would be completely overwhelmed with secure messages, but that really has not been the case. Some of the veterans like to write them on a daily basis, but it really has been a good replacement for the kind of telephone tag that was going on in many cases. There is an escalation process by which, if it's not answered within so many hours, then it escalates to another member of the team to answer the secure message sent to the provider. So it has been an interesting journey, and many veterans have embraced it, but certainly broadening that access, I think, would be very helpful. I think it would help in the post-discharge planning. I think it would help, post an encounter when we're all kind of in the bustle of listening to our provider and we get home and kind of try to remember the instructions that we were given. And another thing that I think will help this is we're also working on a post-discharge summary that the veteran can either access online or walk away with their visit with. VA Blue Button, interestingly, we are a part of the Markle Foundation for Healthcare, and there was a discussion at one of their meetings about, couldn't we make this accessing information easier? And some of it was in response to that, quite honestly, it's taking us a very long time to implement Health Information Exchange, and through the Nationwide Health Information Exchange, now called Healthy Way. But was there another way to get this data back and forth? Couldn't the patient be the conduit for that? So my Download My Data, or Blue Button, was formed. And the idea behind it, it was a simple download that you could download to file, download to print, and then we put the code out there and said to the community, you develop apps for this, you develop ways to use this data, which they did, surprisingly. And so it's really been adopted. Medicare has a Blue Button, and it's been adopted by many insurance carriers. So it's really become much bigger than I think any of us ever thought that it would be. The veterans can customize the data that's there. They can customize the date range. This also came in kind of around the work that we were already doing to put our electronic health record data into the personal health record for veterans to access that information or share it. So it really complements that existing activity. Right now it's in the form of a continuity of care document and is downloaded in something that we call a health summary. In the future, in conjunction with the meaningful use criteria, we really hope that it's a way for the veteran to package it and send it to others. We're also a pilot site for Direct, that secure email transition. We're piloting the sharing of mammography results in Salt Lake, and really hope that that also becomes another tool for the veteran to make that data portable to send right from the My Healthy Vet site to other providers. Open Notes is a collaboration that VA signed on to with several other healthcare providers around the country to really just do that, to make sure that information was available. When we first started putting veterans' information from the electronic health record onto the personal health record, we had a 7-day hold. And some of that was because I think there was kind of a fear that people would get results before their provider could speak with them. There was a little irony to it in that if you went to the release of information office in the medical center and the lab was done or the diagnostic test was done and completed and signed, the release of information clerks didn't apply any kind of a hold to the information. But I think this is an example where health information leadership is needed too. Is, in some cases, why are we applying different rules when something becomes electronic than we had in the paper or the face-to-face environment? So over time, I'm happy to say we've went from 7 days to 3 days, and are still taking baby steps toward reducing that to be, when the test is finalized, to make that available to the veteran. So I know one of the posters was about, I think it was really more about project management, but the subject it chose was release of information. And I would say that my goal is that someday the goal really should be there are no release of information offices. There really is just the veterans and patients everywhere's access to their information without them having to call or write or walk into a specific place to get this information. And I think we'll know we've come a long way when that occurs. But I do agree with the concept that as HIM professionals, it would behoove us to really understand project management principles. I can tell you that in our own organization, I have an HIM professional that's leading. She's the program project manager for the implementation of ICD-10. We handled the implementation of nationwide voice recognition as a project. So I do agree with that project management rigor. I just hope we can get rid of the release of information function. The other part of this tool set is the Veteran Health Library, and it was really so that there are trusted sources of health information. So it starts of the basis of a commercial product and also online access to Medline Plus, but it also was augmented by those things that are specific to veterans, so exposure to Agent Orange, post-traumatic stress disorder, and just a variety of the exposures and military service exposures that would be relative and related to veterans. So it was a collaborative process with the vendor that we bought the core information from. I think this speaks to another one of your posters about that we have different styles of learning, and some of us are auditory learners, some of us are visual learners, so we try to add a mix of components to this health library. And I think most importantly, the veterans can really trust that there's this information is valid. I'm sure that many of you suffer from the problem where patients are coming in with reams of information that they've printed from the internet with competing guidance and competing analysis. So this was really to help to serve to have that trusted source. So all this is about easy access to information and easy access to your providers. And bear with me here, Ryan's taught me how to do this. I think that this veteran and this provider say it far better in this video than I can tell you in words. So where do we
need to use technology to reach out to patients so that they have access to information, decision support, and the ability to communicate with us using technology.
Dr. David Douglas is a pioneer and advocate in bringing secure messaging to the VA community.
In the old days, your interaction with the patient was limited to the time of the scheduled appointment, maybe to a phone call. Now that we have secure messaging, I can communicate with my patients 24/7, any time of the day or week that they contact me or I need to contact them, we have the ability to communicate.
Devin Nosbaum, a veteran of the war in Iraq, describes how secure messaging works for him.
I really like using secure messaging because I can do it whenever and wherever from my smartphone. If I'm walking down the street, if I'm in a coffee shop, if it's 2 o'clock in the morning and I have a thought or a question about my health or medications or almost anything, I can message my doctor right then and there. I don't have to wait for 8 to 5 Monday through Friday. I can make a phone call. How's things been going?
Very good. I'm still very grateful that you taught me how to use secure messaging on my mobile phone.
When I do see the doctor and I've already talked to him about secure messaging or we've already exchanged messages on secure messaging, we can kind of put that issue aside and talk about the current issue that I've showed up at his office for or whatever checkup we're doing.
The service is available to all veterans, from Devin, who grew up with the internet, to veterans who served before the electronic age, like Vietnam veteran Larry Ubel.
First met Dr. Douglas, and he introduced me to this program and asked me if I'd want to be a part of it. I said, well, yeah, I'm not a high-tech, type of person. I'm kind of old school. So and I still like that, but I found it really easy for the secure messaging, and it's been great for me as far as being able to contact Dr. Douglas during some times that I needed maybe just to talk to somebody.
Stay in touch through secure messaging.
You bet, you bet. Thanks.
What the process of secure messaging can do for the patient is it just takes a lot of stress out of having to leave their home, maybe if they're disabled or don't like being out, or it's hard to get to the VA through buses or taxis or something like that, having to arrange a ride. It makes it a lot easier to interact with your doctor wherever and whenever from your home or from your smartphone.
There are over 500,000 vets using MyHealthyVet to communicate with their doctors. Dr. Douglas's goal is to have all veterans using the program.
To veterans and also to my physician colleagues, I would say jump in. The water's fine. You'll be very happy that you did. Secure messaging is a huge improvement over 20th century communication medium. It's more efficient for us, it's more efficient for the patient, and it'll make you do a much better job of providing care for our veterans.
So, an interesting, our current acting Undersecretary for Health, Dr. Jesse, still has he's a cardiologist, he still has a clinic at the Richmond VA on Fridays, and his patients really shamed him into that he wasn't using secure messaging yet, so we had to send people up to train him one day to get him right on, because and that's really where it comes from. When consumers start asking for these things, I think that that's a big part of this, that they know even what to ask for. So it would be great to expedite the rollout, because I think 500,000 veterans is a pretty small percentage of our population, but I think for those that have used it, really it has proven to be quite a useful tool, and it also speaks to it. We're piloting a lot of, especially mental health sessions where the veterans are given iPads and they have their counseling session via whatever modem they want to use, whether it be FaceTime or other ways to connect remotely. And what we found that it is more enabling for them to be in their home and in their own surroundings, and many times if their provider were traveling, and I think it's not unlike the instructors here, that it really frees you up to be not confined to geographic locations. And now it won't forward now. Thank you, Ryan. Thank you. So my staff will tell you that just because I'm in informatics does not mean I'm the IT guru. So I alluded to this a little bit earlier, this whole journey we're on for patient-centered care, and part of this is the implementation and the introduction of a healthy living assessment. And it really, you've probably all taken them. You indicate lifestyle, I'm a smoker, I never walk, whatever the case may be, and you will get your real age and your determined age, but more importantly, you will get those interventions or those changes in your lifestyle that you can do to increase your health status or your age. So we're just in the middle of implementing that. We've made it available to veterans and to employees, and really to start that and enhance that whole goal of prevention and heading things off before they actually become bigger problems. The other thing this gets at is this whole thing is, what is the outcome for me? And that it's more of a personal goal than it is just reducing my blood pressure or losing weight. It's really, what do I get personally at the end of that? What do all those things prohibit me from doing today? Excuse me. So these are to be used as tools for discussion between the veteran and the provider, but also for the patient to do some self-management. And the goal is to have all veterans complete this. Patient-generated data is another area that I'd like to see all of you take on as a challenge. Where should this data be stored? Who owns this data? Should that data be something that presents during the course of the clinicians using an electronic health record? And to just give you a flavor of this, it's the things that patients enter into a log if they're keeping their blood sugar. It may be things they transmit via telehome health buddies or other remote monitoring devices. It may be the results of their Fitbit, and it may be that they're transitioning into different medications. How are those affecting their mobility? Is there fluctuations in their weight? What is the consistency with their blood pressure? But I will tell you, we struggle with this, and right now we have the data in a variety of places. So from the telehealth monitoring systems, we have it in one place, and those are systems that nurses actually monitor the feeds coming from these home devices, and they may be scales, they may be something that I key in, how do I feel today, my blood pressure, my weight, my blood sugar, a whole variety of information. But we see this information expanding, and trying to figure out, A, the volume of it, and B, is it relevant to the practice of medicine? How do you effectively present it to somebody in an electronic health record? How do you factor it into your clinical decision support? I think is a challenge that we have not solved. I don't think we've solved it in the VA, and I don't think we've solved it in the HIM world either. And it's certainly an area where I would really welcome collective wisdom to try to figure this one out. So it also includes this, we spoke a little bit about the blue button, about the patients using that to transition information to other providers. But it also is tied to the health living assessment. What interventions am I doing? What things am I changing? Does it reflect in the adjustments of medications that we've provided to you? And just better prognosis of how those medications are working for you and how those interventions. So I hope to see a poster on patient-generated data next year, and with the policies expanded on and guidance going forward. So one of the first mobile apps that we developed, and I saw some great examples of mobile apps earlier, was a PTSD or post-traumatic stress disorder app, and it was developed in conjunction with Department of Defense and with veteran input. This app has been downloaded millions of times in dozens and dozens of countries and has been used widely. We don't retain that data. It's strictly interventions for the individual. It's been used not only from those suffering PTSD from experiences in the military, but also those suffering from PTSD from traumatic life events. So it was really our first foray into an app. Now we're in the middle of developing a VA-approved app store that will carry, I didn't know what they were called before, I thought this was gum, but the chiclets that represent, that we all have on our iPhones or smartphones. And one of the next group of apps we developed was actually for a very select cadre of people, for those severely injured veterans that have caregivers. They are stipend caregivers. We built a set of apps so the caregiver could easily access the VA information on the veteran, the DoD information on the veteran, and provide for them social networking with other caregivers, provide to them stress-relieving components. And so we've also had our librarians involved in, they've developed an app that brings together all the VA online resources that we purchase, whether they're periodicals or references. And so, like many of you, we have lots of people developing apps for different specific areas, and it's fun. It's you can fail early, you can fail cheaply, and you can succeed quickly and early. So I think it's really an area where we're trying to marry the advancements of mobile apps with the advancements in our electronic health record. You know, can those mobile apps really augment that kind of larger monolithic electronic health record system? I alluded to this a little bit earlier. We had a program that began as a pilot about 4 years ago, and as I said, Madison was one of the pilot sites, and it was really to build this cadre of analytics expertise within the VA. And so I have a staff that provides national reporting and national analysis, but you still have that need to look at your local data. But I don't know what it's like in your facilities and in your workplaces, but the people that know how to work with the data are like gold. They're bartered frequently, and they're stolen from program to program and from hospital to hospital. So really the goal was to build up this in a sustainable model. So it has multiple components. It has a technical component that we're teaching you. Where are the VA resources of information? How do you join pieces of information? It also has an academic component that's done in collaboration with a university program where they actually earn college credits for it. So we took it beyond those 12 sites and now have implemented nationwide. Many of those Veterans Integrated Service Networks have set up their own analytics areas. Many of them have regional data warehouses, and we provide them their data and national data from a corporate data warehouse. So we also provide in our office consultation services. So we will go into a facility and try to help them look at where they should target their efforts. The other thing we do is we're finding, for example, on the patient satisfaction survey, that sometimes people they were trying to increase their satisfaction level, and they would try a dozen things and not analyze the data to really look at where did the problems lie. Right now we do national patient satisfaction. There's lots of criticism of it because it's very much retrospective. Sites do not get their data for 3 to 4 months. So more and more of the medical centers and clinics are trying to do real-time satisfaction data. Some of them in the inpatient environment, for example, are using products like Get Well Network, where you can, the nurse just left your room and you can rate the service that was provided to you. So I think one of the lessons learned in the past few months has been this whole thing of really relying on your satisfaction data as much as you rely on your analytic data and your numbers, because really the satisfaction data really pointed to an access challenge for us. We also think it's very important that leadership use this analysis and this information as they make decisions, whether it's hiring decisions or where to build a new clinic or just any decision within the facility, really getting leaders engaged in knowing what questions to ask and incorporating analytic tools into their decision-making process. So in these visits that we do to the medical centers, we conduct an analytics of their maturity, assessment of the staff they have available, the tools they have available, and where they are in their data. Sorry for the busyness of the slide, but as many of you know, and as we heard in the award, HIM has a huge role to play in research. And the contributions from HIM professionals in research is an essential role. And I think for many of us, probably not the most comfortable role or the role where we have the most expertise. But so some of that we've done with pairing up traditional researchers with HIM professionals, and I think we've been pretty successful at that. The other thing we're really trying to do is bring that research into clinical care delivery, so kind of bridging the traditional research where I research for several years and then publish. So we certainly do that, but it's also to take the research information you have to help provide options to individuals as they determine the direction of their health care. So very involved in research. I've had the pleasure of being a reviewer for AHIMA for some of the research publications, and I think we've come really a long way. We have one of the few PhD HIM professionals in VA who's doing a lot of research about the use of electronic records and disease intervention and outcomes, and so we're very fortunate in that regard. So I just want to talk a few about the landscape that we see today, this whole meaningful use of electronic health records. We first got involved in this in the 90s when Congress, who is our board of directors, asked us, well, you've implemented an electronic health record, but how do you know they really use it, and how do you know it's effective? So just like in the meaningful use criteria, we began with orders directly entered by ordering clinicians, those that had the authority to order, and what was that outcome from that. And as with the rest of you moved on to stage 2 meaningful use, tried to look at how to implement these things within current systems, with a side out to stage 3 meaningful use. But it's certainly been a journey. I think there's a lot of controversy surrounding are we going too fast into the different stages of meaningful use as the technology progressed to be at that level, and but we're diligently working on stage 2 with an eye towards stage 3. For us, it was a commitment by leadership because we do not receive the extra payment from CMS. We are not allowed to bill Medicare or Medicaid. So certainly looking at what is really the clinical benefit of moving to meaningful use. We talked a little bit already about the health information exchange and our experience. We are expanding to 200 additional sharing partners this year. One of those is taking Kaiser out of San Diego and going more broadly. The other interesting collaboration we had this last year was we entered into a partnership with Walgreens where we shared immunization data. We had noticed that both for employees and patients that we were seeing dwindling numbers in immunization, and many of us hypothesized it wasn't really because people weren't getting influenza vaccines, but I can tell you that on Saturdays when I'm walking through my local CVS and the pharmacist says, just show me your arm, it's easier to do it there than it is to stand in line for a flu shot at the facility. And I think veterans are, like everybody else, that convenience factor. So we entered into the agreement with Walgreens, no cost agreement. Could we share the data back and forth, which we could. We both worked on refining that whole issue of identity. We're working with them now to see if they could accept the Veterans Health ID cards. And so we successfully proved that we could share the data, that we could bring it into our electronic health record, that we could embed it in the record, and so the providers would see not only influenza vaccinations delivered by VA, but also those delivered in a retail environment. We hope to expand that out to any retail provider that would like to participate in the next year. And but it was really a learning experience. There's a flagship Walgreens, I don't have Walgreens stock, but there's a flagship Walgreens in Washington, D.C. in Chinatown, if you ever get the chance to see it. It's a beautiful store. It's right by the Chinatown Arch, and it's 3 levels, and in the bottom level, they have a 3-pronged approach to delivering health care, and they have a pharmacist there that will do clinical counseling. They have the pharmacist at the counter that can do all your immunizations, influenza, but if you're going abroad, they can do all those too. And then they actually run a clinic there. They're in an accountable care organization with local hospitals, so if somebody presents with something more complex than they can handle, they certainly quickly route them. But it's a great place for school physicals or urgent needs on the nights and weekends. And I know that there are some, like TRICARE, that have tried to see if they could reduce ER visits by collaborating with Walgreens and others to see if some of these things like the minute clinics and things can really offset those ER visits, considering many ER visits are not for emergent needs. So that's an interesting collaboration. And I think that's the name of the healthcare environment today, is partnerships, collaborations, because it just makes learning and advancing so much stronger. The analytics and big data, as I said earlier, we're working with Kaiser, with Johns Hopkins, and with others to really look at, what are some of those things that we can challenge the data for to get new insight? Can we look for trends across our shared patient populations? And then this whole issue of privacy and security, again, you had a poster session and more about the privacy and security of mobile. Is it that risk-based decision you make to go to a wireless network? What does that expose you to? What are some of those just common sense precautions that you take? So, for example, and in the poster session they brought this up, those devices that we issue immediately, number one, we don't store patient data on the device, and number two, we can wipe them clean with a moment's notice from a provider that the devices come up missing. Same way with our BlackBerries. I was going to say, that's how you know that it's a VA provider, because he's one of the few people still carrying a BlackBerry. So, but I think that exploration of privacy and security, and I'm going to go out on a limb here and say I think our profession, whether we were rightfully accused of it or not, we've been pretty risk averse, and for understandable reasons. But these areas where we have to have, so I would say the HIM staff that works for me and our general counsel and the information security people, we've had to really work on. No is not the first thing that you should say. That you stop, think of ways that maybe you can get to yes. But I think a lot of these are risk-based decisions, and I don't think generally as a profession we've been a little risk-averse, and maybe that's where we stay as a profession. But I really think we're going to have to think of ways to work with the security people and with the attorneys to figure a lot of this out, because I don't know about you, but for us, the residents are using these things. The resident, not a resident walks into a facility without, an iPad in one pocket and an iPhone in another pocket. So figuring it out and figuring out how they can do this in the most secure way possible is really the direction I think we should go. So we constantly monitor the unintended consequences of health IT? Is it a training issue? Is it this? We have a National Center for Patient Safety in Ann Arbor that was really modeled after aviation, and then we've added to that what we call IT patient safety. So people are encouraged to report near misses, anything they think was unusual about either how the software worked or how a process worked. And really that's a vitally important way to really find out, did you release something? Did you not test every aspect of it? And we are our own vendor, but I think you have to have those processes. I mean, I think these are questions you ask if you're contracting for an EHR too, is, what mechanism do you have for reporting these things and trying to recover them? So, but certainly not every piece of software works as it's intended right out of the box. We're doing more and more with usability. When I talked about earlier about getting the same look and feel across these things, the different veteran applications or patient-facing applications. We do a lot usability labs with veterans, usability labs with providers. Are there too many, the providers will tell you there's too many clicks. I have to click 20 times to get from here to there. How to reduce those keystrokes and facilitate the logical introduction of technology. For us too, we train about 80% of the nation's trainees. So they're coming in and out of our facilities and the academic institutions, and we've got to make things really intuitive for them because we get about 4 hours with them to train them on our electronic health record. This whole issue of information governance, who owns the patient-generated data? What about the data? Are some people caching the data that you get through the eHealth exchange? Ultimately, does the patient just own that data and override any decisions that you may have? Right now, for the health information exchange, we go through a laborious process of veterans signing a release of information. Part of that is because we still have a restriction for drug, alcohol, sickle cell anemia, and HIV. So with that, I cannot use the provisions within HIPAA that would let you share for treatment, but it's certainly really slowed down the progress of adoption of a health information exchange. The evolving reimbursement models, which affect you right now much more than they affect me, but I know that every day they're changing the whole thing of non-payment for readmissions. And we do look at our data across Medicare because we have many patients that are going back and forth between using VA and Medicare, and what do those readmission rates look like when you go back and forth. Unfortunately, we don't get that data for about 2 to 3 years after it actually occurred, which is really not an opportune way to make any meaningful interventions at that point. So what can health information professionals do? I don't hear this as much anymore, and I'm so happy about that. This worrying less about usurping our traditional roles in the industry and the industry valuing us. 20 years ago, it was that we were in competition with nurses. I will tell you, I have nurses on my staff, HIM professionals, physicians, and it takes all of them to make this work, and they all have a role. And worry more about the impact of information on outcomes. And quite frankly, that's where VA is today, that it's much more important that outcome was than that I monitored, in this example, the wait times. And be an advocate for strong information governance. Be the person at the table when you implement your EHRs or when you're deciding on your analytics platforms or when you're deciding what organizations you share and merge data with. Be there when you decide how and when you're releasing information to veterans and how you're making it easier for them, veterans and other patients, to access their information. But you need to be at the table. You don't need to wait to be asked. You need to be making the case of why your skill set and your expertise is absolutely needed in the area of analytics, electronic health records, information governance, process within a healthcare organization. You are a credible, essential component of that, and don't ever forget it. And please don't wait to be asked. Please don't wait. So, what can we do? We can provide more education for everyone. I mean, I feel so blessed that there are curriculums like Scholastica where it doesn't matter in an organization where I have people literally from one side of the United States to the other. They can take master's level classes. I've got students in law school that are taking this virtually. This whole idea of reducing the barriers to obtaining education, I think is just an amazing progression that we've made. And this is going to be a little, probably more controversial. Focus less on the technical careers and more on the knowledge careers. Even if your foundation, my foundation was I was an RHIT, then an RHIA, because quite frankly, I didn't know if tuition reimbursement was going to carry me through all the levels. So just, never stop learning and really advancing those skill sets that you have. And keep outcomes central to everything that we do. The outcomes at the end of the day are the important part of this. Not the numbers, not the statistics at the end. They're a vital piece of information, but what outcomes you achieve are just really essential. And demand and support research and evidence from our schools and our professional associations. Collaborate with schools to solve a problem you have in your organization. Look for the researchers in HIM. There's so few of them. Please support them in every way that you can or become one yourself. And volunteer. My staff think that I volunteer them a lot, but I think it's just so important, and I will tell you that every minute that you spend volunteering comes back to you tenfold. The people you meet, the opportunities that you get, there's just nothing like it, whether it's volunteering in this profession or volunteering in your personal life at your church or your schools. It's a remarkable thing, the amount of pleasure, personal gratification, and just building yourself that you get through these volunteer activities. And there are limitless opportunities. If you're not familiar with them, I'm sure every one of your instructors here, for you that are students, can let you know what those opportunities are. But I just encourage you to volunteer. And that's it. Thank you. And now we're open for questions, and you'll bear with me. I am to repeat the question and then answer. So, no questions. Mm-hmm. Okay. It is. Shirley just asked about the intern program within the VA. Actually, one of your colleagues is in part of that program. It's called the Technical Career Field Program. We accept both RHIT and RHIA professionals. Some are new graduates, some are those that apply to come in. We do about 12 positions a year, and I'm looking for Nellie. And I can, I'll be sure to send all the information. If you have anything to add, please. So we've had great luck with placing them. We work with you to tell you where, it's a 2-year program. We work with you to tell you where there are opportunities. Some apply for traditional directors of HIM programs, but some go into other positions, administrative executives to surgery chiefs of staff, et cetera. Some go into analytics, but I don't know, Nellie, if you want to talk about it. So I'm going to try to summarize what Nellie just said for them. So Nellie's in the program. It's a 2-year program, and the location is dependent on where we have a mentor. We train a mentor, and you go to that mentor site. So at any given time, we have like 24 to 36 people at some stage in the program. If you choose to relocate at the end of it, we pay the relocation expenses. During the time you're there, we pay the salary of the individual. They're also guaranteed so many hours of continuing education during their technical career field period. And in VA, this is one of about 24 technical career fields. We have some for human resources, some for finance, and a variety of other professions. But it's been an amazing, it's just one of our succession planning tools, but it really has been a way. Many times it was difficult for us to bring in new graduates, for example. You know, you're in that catch-22 where you don't have the experience, but you have the education. So we've brought in some just amazing people like your colleague here. So I encourage you, and we will send a package of information. We're happy to do, post any information. I believe we still have it on the AHIMA site as well when the application period comes around. usajobs.gov. You heard it here. So yes. Okay, and you have to see some of the posters there. So the question is, because we're nationwide, so Kaiser is probably the most closely reflective of our situation. How did we comply with different state regulations? We did not. So in that local exchange, we apply the federal regulations to the veteran engagement in the exchange that we facilitate. But we can accept data from anywhere. What we do, will not do a different technical solution for every state or even every component within a state. We have one technical solution that we use, and now there will be two. One is what was the Nationwide Health Information Network, now is Healthy Way. So we use those technical specifications to exchange data. We are adding the secure email, in part that we know small providers will not be able to do the larger health information exchange. Right now, because of our provisions for for us to enroll in veteran where we send their data somewhere, they do have to opt in at this time. So that's really, that process, the opting in, kind of the heavy weight of that process, and the identity matching, I would say, are two of our biggest challenges. Lots of interest, but many of the states want you to conform to a proprietary technical solution they've developed, and we really honestly can't afford to do a different solution in every locale. So those are probably the two big things right now. And originally, we uniquely required an authorization from the veteran. It does appear that more and more are requiring opting in or an authorization from the individual. So there is a move afoot to make that electronic, because right now what happens is, if I'm going to share with Indianapolis, we do a patient matching of shared patients. And then we actually send letters with the authorization to all of those veterans in that particular geographic location. So we'd really like to move away from, that veterans hear about it and decide to enroll. We had several rural health pilots for health information exchange. One of those was in Salt Lake City, where we worked locally with the people, but we were using the technology it's the same technology we use to share health information with Department of Defense. Okay. Well, you've had a long, oh, go ahead.
So I have a question about the big data component.
Uh-huh.
If you have taken a centralized approach in terms of folks requesting data to be able to make decisions, or if it's a decentralized approach?
The question is regarding big data, if we've taken a centralized or decentralized approach. And as in most bureaucracies, yes, to both. So actually, it's become a collaboration. We have an organization that provides the national data from the data warehouse and post that, and you can sort it by facility, you can sort it by VISN. So we do a lot of the national reporting for everyone. But we also have made sure that there are trained people locally to do some more real-time analytics, closer to where the care delivery is occurring. So, and many times what we'll do is locally, they may have a couple clinicians that will sit down and work through a report with them, and then we'll take a look at it to see, is this something we could take nationally, or do you really need that? Does it become meaningless when you roll it up? So we do some of that, and sometimes we'll take the work that they've refined and put that into a national report for them. So nationally, I have people that do productivity reporting. I have a group of about 8 people that do clinician productivity reporting, and then we have a group that does clinical and business reporting on a national basis, and then we have the people that are trained locally to do analytics. It's been a long day for many of you, I know. So anyway, it's been such a pleasure. It's a beautiful city, and I've been such a fan of both Shirley and of Kathy and of St. Scholastica as a whole. I've had the pleasure of working with many St. Scholastica grads over the years, and always well-prepared individuals, and I just applaud you for picking such a great place to advance your careers and for the just innovative ideas and things that you've all come up with that I saw earlier in the session, but thank you.
Token of our appreciation, a small gift. We stayed under the $25
Okay.
limit, so don't worry about that.
I don't need it.
We do not want any more drama in
Yeah.
your life.
Okay.
One more round of applause for Gail Graham. Thank you so much for your leadership and innovation in the HIM industry. Obviously, you've been very busy over the last 27 years, so great work. And thanks to all of you for coming out for the LaTour Eichenwald Forum this year. It was great to see everybody. I think the best thing about this program is the community of alumni, current students, and friends and colleagues that actually make to keep improving the program as we move forward and addressing the challenges such that Gail presented today. And I think the number of people who came out and the networking that was happening is a good illustration of why our program is so great. So thank you all. Be looking for announcements of our program next year, and I hope to see you then. Thank you.